Well, if you're not one of those who, because of certain conditions, falls into the so-called high-risk category. Now, you might want to ask me, who are these people in a high-risk category? Because that should be your next natural question, shouldn't it? Now, the answer to that question is, once every year, if you belong to this select group, and that select group comprises, if you have a family history. When I talk about the family history, there are various forms of family. There are syndromes that occur in the family. Kaul, lots of them, which have breast cancer as a part of them, and they run in families. So you've got to identify. The commonest is the BRCA gene family, where the mother's mother, then from your mother's side, from your masi, from your sister, anybody having that kind of a relationship, breast cancer's history earlier, will need to come once a year. Also, then you need to get your gene testing done. You want to do a BRCA1, BRCA2 test, which is commonly available. Because why? It's important for you to know that you're at special risk, so that you may want to consult, get genetic consultation as to how to deal with it. Because your chances of getting the breast cancer are almost up to 85% if your BRCA genes are positive. So that if you already had breast cancer in one breast, then for the other breast, you are a special candidate. It's most likely to happen. Okay? If you have an inflammatory breast condition like florid multiplication rate in your breast cells, florid epitheliosis, or if there is dysplasia, which means that process, that multi-step process of carcinogenesis that I talked to you about earlier has already begun. And if you catch it in that stage, then it has not become invasive malignancy. It's tending to turn into a stage just before the cancer, which is called carcinoma in situ. C0, carcinoma in situ, which means just the step before the invasive cancer. The earliest breast cancer is carcinoma in situ, where it has not become invasive. Now, so if you catch people even before that in dysplasia through a FNAC or some kind of biopsy, then these girls are more prone to get that breast cancer. So you've got to make sure that you look at them very often. If you had unhindered hormonal medications using estrogen alone tablets, which means you're particularly there, you told early age, at late age, at first pregnancy, marriage is not important, at first pregnancy, and a late menopause, when you stop your menstruation much late, which means that whichever life gives the bad estrogen, the estradiol, 8-estradiol, enough time to work on the target organ breast, long time, these women particularly are prone to develop cancer much more than others. High obesity, earlier history of endometrial cancer of the uterus, diabetics, these particular people, when you have more than one factor, the chance of getting the breast cancer more increases. So if you are one of these special women who fall in this category, then you have to have a test once a year. You don't have an option. And if you are not one of those, and since you know that breast cancer, most of the time, all breast cancers are not hereditary, they're not genetic. It's just 10 to 15% of breast cancers which are genetic. The others occur sporadically. Which means the message is there in your gene, but it comes into a clinical form in one generation suddenly. So there won't be any history. It'll just come de novo. And these is maximum women are in that category. They're fine if they have a test once in 3 years. I don't think we need to overdo things as well. And of course, these policies are dictated by the statistics of women who get breast cancer in a geographical area. So while the Americans now, we are getting, because breast cancer is changing demographics also. Earlier on, women above 45, above 50 had more chances of developing breast cancer, but there's been a generational shift now. If you look at the world demographics of breast cancer, young women with breast cancer are coming up more and more. Early stage breast cancer is getting diagnosed more and more. So patterns change over a period of time, and epidemiologists who deal with disease need to keep watching them. And you need to make decisions based on these, on data, on statistics, on evidence. Because today we practice evidence-based oncology, don't we? There would be some penetrance of that trait, particularly adenocarcinomas. These are called cancer families. But the usual main inheritance is in breast cancer is from the mother's side. There would be a very small percentage of cases where the family is an adenocarcinoma family. Gastric, pancreatic, same histology cancers coming up in families through the father's side also. That happens as well. That is why now it's become so complex, and research is throwing up so much that even for one person to know all this and become expert in all this is also difficult. So that's why a good cancer team will have access to a genetist also, who do your family tree and tell you that if there are such cancers in your family, what is the chance that that can get transmitted to you? Because you want to take decisions which are correct, which are guided by science.